This is not Bosphorus. This is Prince Islands around Istanbul. And still waiting the presentation. By waiting, I would like to thank you for re-invitation again in your country. And I'm really glad to discuss and talk with you. The topic is somehow unusual to discuss, because while we are saying intracranial dissection, of course arterial dissection, we don't know yet what we are talking about. That is the problem of us. May I have my presentation? Really? Okay. It is on, but not seen there. Can you come and see? Yeah, that's it. It's already.
Just start the full screen.
Okay, I did it, but it's waiting you. These are the jobs I did up to now. First of all, we need to know that we have less information about the intracranial dissection. Let's have a look at the theoretical background of it before showing the cases to you. Incidence unknown, but most probably lower than the cervical vascular structures. And also that proportion and location of the dissection is changing according to the ethnic group. The Asian has more prone to have dissection, and age, also the study recruitment style is affecting the numbers. For example, in Asian, males are dominant. In non-Asian, almost equal female to male. In pediatric group, that more male, mostly on internal carotid artery. Mean age is 50, but can be seen every age in the pediatric group also. And the rupture rate is more in older. Per definition, we all know that for the dissection, there should be the disruption of the intima and endothelium that let the blood go in. But there is other mechanism. We are forgetting about it. That is the intramural hematoma, which is the one of the main diagnostic, the image that we are following. We are forgetting this. That intramural hemorrhage may lead to rupture or intraluminal rupture, mostly from fragile vasorum. Pathophysiology is unclear. Everyone is discussing about it. We have less support, but we know the anatomy and pathology of the brain vessels has lack of external elastic lamina and thinner media, prone to have more dissecting. If it is so, why the cervical dissections are more than intracranial dissection? Is a question, maybe underdiagnosed. I am in favor to have a look at the vasorum, but it is discussable. There is no consensus on it. Also, the entry-only or entry-exist morphology is very important for rupturing the features of the pathology. Also, blister and giant fusiform aneurysm pathomechanism, for me, it looks like a common pathway. I'm not saying that the similar, but the common pathway of the vessel. Also, the mycotic or oncotic aneurysm have using the same pathway to create injury of the vessel wall, which mostly coming from vasorum mentality. Risk factors is unknown, like those. You cannot blame any of them. Presentation is important for us. That is our pivotal point of to look at the cases. Rupture or ischemia almost half and half. There is no specificity of the ischemic lesion. Every kind of ischemic can be seen. Occurrence of both in the same time rare. Mass effect, especially in the thrombose aneurysm part. And most of them presented with headache, which is very unspecific. Problem is how we are diagnosing it. This is really challenging, because of the small size of the vessels, subtle findings, suboptimal equipment what we are using. Also, the disease itself very dynamic, changing the morphology very dynamically. Intraluminal part of the diagnosis, of course, the gold standard is the angiography. That focal vessel wall irregularity is one of it, and pearl and string sign and occlusion of stenosis. All of those have a value. But when you see the intimal flap, okay, this is dissection, we are all diagnosing it. Or double lumen, okay, this is a typical dissection, what we are saying. There are other things for aneurysm. If the retention of the contrast media after clearing up the contrast in angiography is a very, very interesting finding. That is a kind of dissecting feature. Also, the intramural pooling of the contrast media and without having aneurysm is also another feature of it. For extraluminal imaging, which is very, very important in the dissection, the first one is the mural hematoma. If you saw the mural hematoma, that is mostly taking you to close the correct diagnosis. Also, the intimal flap, double lumen can be seen there. A lot of differential diagnosis. But it is confusing for us, especially on vasculitis, especially on non-vasculitis, but atherosclerotic vessels. So you can collect all of it and get some proposal for diagnosis to get a real diagnosis, still missing, by the way. This is a very typical example of the mural hematoma. And then the MRI is a good tool for it, especially non-contrast, the T1 weighted images, and also the other sequences let you say so. This is a typical example of double lumen. No question, there is a dissection there. Please don't miss the double lumen with the intrathrombose hemorrhage. That's why you need to check whole sequences of the MRI before saying double lumen. This is a very typical pearl and string sign. This was a Behçet disease. The case has a Behçet disease, a ruptured superior cerebellar artery aneurysm, and we are treating it with coil. Look at that proximal and distal narrowing. This is a very typical example of focal vessel wall irregularity, which is very compatible with the infarct on this territory. Look at the enlargement of the anterior cerebral artery A2, A3, and A4 segment. Also, the same corresponding infarction. How we manage it? How we manage the ischemia without knowing that there is an ischemia, there is an infarct, there's a dissection or not? Really, it is confusing. Every team is acting differently, even the member of the team acting differently, because the safety efficacy of the intravenous intraarterial treatment is not proven yet. Anticoagulation or antiaggregation also, it is not proven yet. There is no study on it. And that's why the physicians try to be on the conservative side, not on the treatment side, most of the time. This case had repeating symptoms, repeating infarction on the MCA territory, and even though she's getting the best medical treatment. I was passing through to the radiology department and somebody asked me, what is it? And I just saw those three pictures. I picked it for you. I said, we need to do an angiography. And they accept what I'm saying because I realized something going on there, and I was right. This is the intra-arterial cone beam CT angiography images clearly show the dissecting, starting from internal carotid artery, ending to MCA. And then things change. Now the patient had already got best medical treatment and already have repeating infarction. That's why medical treatment is not a good option for this. And I intervene it. I put a stent, and the story is gone. The patient never had any infarction after stenting. Another one, again, best medical treatment, repeating infarction on the posterior fossa. MRI, there is something here, and the radiologist warning the clinician that there are something there. What is it? There is a lot of loop in the subclavian artery in the vertebral orifice. I did an angiography. See the angiography. In the conventional angiography, nothing at all. Worse than MRI. Should we continue to give the best medical treatment? No. This morning cases, Momo, I didn't comment on it. What is missing? Best imaging technique was missing, and they did a fold, they did a complication, they move forward. Why you don't use the best imaging technique in your angio system, that is flat panel detector CT angiography, clearly showing the dissection? And then you may change your mind, change your stent selection, change your medication, and do whatever you want. I'm not saying that after seeing the dissection you will intervene in a different way, but there is another, the pathway is creating by these images that you are sure that intima is injured. And this is clearly a dissection, and then of course I intervene it. Why atlas? And the discussion also goes to that internal carotid artery. I'm not using internal carotid artery atlas. For me, that the Italian case, for the loop, I will do the pipeline or derivo because of the size of the flow diverter, because of the braiding technology. At the curve, laser cut stenting is a fault because opposition. Opposition is important. Why we are attacking the intimal injury? We are pushing the flap against the vessel wall. That is our aim. Why should I create another gap between stent and the vessel wall? This is totally against our target. Braiding stent technically give you a chance to push the flap towards the vessel wall, get rid of the gap, push the intima into the media. That's why for this one, I didn't use braided stent. I don't want that flap is actually go to the vessel wall because of the fear of these perforators occlusion. That's why I choose Atlas, because Atlas there are gaps, and that there are gaps letting these vessels still open. But in other places, I will use the braided stent. So again, this case didn't have any other the stroke incidents after the stenting. What would you do this? No infarction, headache. And we found that ugly shaped C1 segment. We all know that C1 segment is prone to have a vasculitis. Also the dissection. Which one is which? Vessel wall imaging shows nothing. No contrast enhancement. So what to do? I didn't intervene it because the patient has no infarction, just a headache. And I gave the anticoagulation. 1 year later, look at it's totally cured. Another case, again, no ischemia, headache. We found the same segment, stenosis, an ugly shape. Maybe dissection, maybe not. My strategy on dissection is not intervening immediately. We need to take care of that, the clinical findings. We need to take care of the attack number. And so, again, I wait. A year later, everything is turned back normal except Again, the intraarterial vasocity clearly showing intramural dystrophic calcification. That is something that I'm observing all the time in that dissected group. It is happening in dissecting aneurysm. I will show it to you. Another one, drug addict, cocaine, young, got an infarction. We all know that. Okay, cocaine can do it. But can we able to see the dissection in the conventional angiography? Not always. You need to do your best. That is the best intraarterial contrast injection and cone beam, clearly showing that the flap. Okay, should we intervene it? Have a look at the clinic. If it is stable, just wait. Load the patient, just observe. Put the patient on the hospital. If it is in your hand. You need to wait. You need to create an optimum antithrombotic agents for stenting. I'm ready for it. But the patient stay stable. And then I didn't do it. In 2 months later, everything turned back normal. Look at this. This is the dissection 2 months later. Just don't need the coumadin because we cut the antiaggregation after echo stage. This is something a balanced case by case. We should not put stent in every case, even though we saw the intimal flap. Another case, ischemic lesion, young female, headache, and just at the proximal portion of the MCA, there's a narrowing. This is the overlapping of vessel imaging and angiography fusion. That is the flat panel CT angiography fusion. Clearly show the contrast enhanced part of it. When dissections also have contrast enhancement, but less than vasculitis. And then the patient categorized as a vasculitis, even though we haven't got the perfect laboratory findings. And we wait. Look at this. The vessel imaging is a perfect tool for follow-up. In 2 years, look at the contrast. Eccentric contrast enhancement is gone. That is something what we are doing in the city. Mural hematoma is one of the main factors that is giving us a chance to have diagnosis. This is a case had an anterior thalamic artery infarction which is arising from posterior communicating artery because of the dissection and creating a small aneurysm. It happened. This is it. This is a fetal type posterior communicating artery. I write this a bunch of cases years ago. While we were waiting the silk stent at those time from France, it spontaneously healed by himself. It is happening time to time. Another case, clearly showing the mural hematoma. Again, the same infarction, anterior thalamic artery infarction, which is arising from posterior communicating artery. This is an aneurysm formation. When I decided to have an occlusion for it, this is aneurysm, it is spontaneously occluded. And this is another case. Look at the fusiform enlargement of the posterior cerebral artery. In 6 years, it happened like that. This is serpentine transformation of the lumen. And this is the CT at the very beginning. I think it is coming from one Balkanian country. I don't remember the name. But this is the mural hematoma, and this is after it. You can explain this with the Coanda effect, whatever. I already write in details in my book, giant book. If you're interested, you may go for it. But the parent artery occlusion is a good option for those kind of the cases. With the good pile collateral, it is getting normal. This is, I think I mixed it. This is the previous case control, sorry. Another case, this is typical for see the stagnation, aneurysmal stagnation, and it is coiling by preserving the posterior communicating artery. And this is a year follow-up. Another one, ruptured fusiform dissecting aneurysm. Now we come to the rupture group. As you see, there is a mural hemorrhagic calcification. It is very the same with the non-ruptured group, this more dystrophic calcification. And this time, I treat with the flow diverter, which is hemodynamic treatment mentality. Acute stage, the edema, everything is, you need to deal with it. In 2 months, getting better. In 3 years, everything turned back normal. So the management of the rupture group is like that. You already saw 3 examples for it. What is this? This is a rupture. Old, and actually not such young, as over 70 as far as I remember. Conventional angiography, including 3D, is showing nothing. If you don't have a look at it very carefully. That is the pseudoaneurysm on the pericallosal artery, distal part of it. So going there and occluding the artery. This is called the misnomerly the mycotic aneurysm. But actually it is not mycotic at all because there is no septicemia. We did this case, this is the partial thrombosed, dissecting nature, basilar fusiform aneurysm, possibly ruptured. You cannot occlude the artery. And we create this technique in 2000, a scaffolding technique. With those 2 stents are coronary stent. Bayer stent for scaffolding and inflow zone, the cover stent. And look at the hemodynamic change and thrombosis. And by year, 15-year follow-up, turn back normal. This is a perfect hemodynamic treatment without putting something in it. That's why I created the threads, that dual layer stent with the same mentality, another dissecting ruptured aneurysm. At the very beginning of the flow diverter, it looks okay. Serpentine type of aneurysm happened because of the hemodynamic treatment, but 4 months later, the patient passed away because of the rupture. The world is not such simple in dissecting ruptured group, even though you did the best. For the distal aneurysm, I also published the MCA distal group, most of them dissecting in nature. And some example, look at this, no neck at all, saccular fusiform is a good results. Another one, again, fusiform, this is pipeline, this is fret, 4-year follow-up. At the very beginning, if you have a mass effect that distally non-ruptured, we were occluding the vessel and checking the pile collateral as in this case. But right now, we have tools to reconstruct the vessels less than 1 millimeter, and this is happening here. And you may see the location of the aneurysm here, very deep portion of the sylvian fissure, and you can manage to treat this one with the flow diverter. This is Fred Jr., and look at the lovely change of the angle of the distal artery. Technically, it is feasible, and we're very happy about it. This is the follow-ups of this Fred Jr. case. Look at the location. So just some slides for blister group, because I believe blister aneurysm also kind of dissecting group, especially coming from the intramural mechanism. The rupture group in the acute phase, you can able to change the hemodynamic and heal it. And but in the blister group, problem is we don't know the transition zone. This is the typical blister coiled regrowth like this. That's why it histopathologically looks like dissections and also pseudoaneurysm. That's why the trend in the world goes to the stent, especially the flow diverter, even in an acute stage. As we know, the perimesencephalic benign, that is totally misnomer. Rupture. Even nowadays, the neurologist and neurosurgeon doesn't ask the angiography because that thinks that their angiography is invasive. That is, we can discuss. You can see this blister aneurysm time to time in this group and treat this. This is a pregnant nurse, lady, ruptured again, TOF show nothing, and also angiography show nothing. And that is the wrong decision if you stop here. If you do an intra-arterial flat panel CT angiography, you may see that the fusiform blister aneurysm on the thalamic perforator. If you don't do it, forget about the diagnosis. This is a follow-up. Who would treat this one? In years 2003. Rupture, lady, please give your opinion. Please show your hand. Who wants to treat this one? And the panel also. Kamil. Maybe you saw this case, that's why you are treating. And the mentality was in my mind at those years. I treat this one, even though there is no aneurysm visible. I did 2 neuroform, that stent was available. And this is September 2003. Telescopic 2 neuroform in November. But I'm following it because I know that this is a dissecting aneurysm. And in April, look at this. There is a circular portion has appeared. And that made me happy that I did a good decision in September. And I put some coils with the balloon remodeling technique, and then it becomes stable. Even in 2016, it's stable, still bringing me Turkish börek, mostly the ıspanak. As you are seeing ıspanak here, Hispanic. Yeah, ıspanak, yeah. Okay, I passed my time. I'm passing this last case. And for conclusion, we really don't know too much about intracranial dissection. We are doing case-by-case decision, and we are discussing on an empirical way because there is no evidence-based guidelines on it. I would like to thank you again, and we should see you in Istanbul in WLNC next springtime. Thank you.
Thank you, Naci. Excellent images. I'm impressed. What is your protocol, CT protocol, to get these images from the flat panel? Can you tell us?
First of all, you need to put your catheter in a correct place. That is very, very important. Because 2 techniques, I also write about it. First, you need to mix the blood with contrast. This is a technique. Or you can dilute your contrast to get these images. If you give the full contrast, you never get these images. That's why there should be a good mixture of it. The catheter should be internal bulbous or at the orifice of the vertebral artery. And as you see, the Dyna CT or Vaso CT technique is 1/8 or 20 seconds turnaround. And that means the total amount, if you dilute, non-dilute the contrast, 0.4 cc, total 11 cc contrast. If you dilute it, you can give the maximum as you wish.
0.4 in 11.
11 cc
11
total with the blood mixture. We don't need to change the pump by doing so.
So for perimesencephalic subarachnoid hemorrhage, you do for every patient flat panel?
Yes.
Yes. Okay.
Exactly. I'm doing that at the acute stage, and I'm shifting the 3 Tesla nice MR angiography for the follow-up. I'm missing the second DSA. I'm not doing anymore, but doing a best MR angiography with contrast.
And do you know how many those dissection you find in perimesencephalic SAH?
Just having a looking at my group.
Yeah. Yes.
Every year I'm treating one.
One.
Yeah.
Thank you.
You're
One question: when you place a stent in a dissection that is not ruptured, do you do PTA as well, or do you think this is
Never.
not recommended because of getting the hematoma spread away?
Never. I'm
For
never
that
doing
reason,
PTA.
for that reason, or because the dissection that you showed from the vertebral artery was pretty tight, like a
Yes.
stenosis? And you
That's-
just place a self-expanding stent and then it goes
Atlas.
away.
Yeah, because of the radial force of the atlas is quite well. And I never do angioplasty for those dissections.
And have you ever experienced that the stent didn't open? So that meant
For
you were
dissection-
wrong because this was not a dissection, it was a stenosis?
Some
That-
cases, yes, but I'm preventing myself to do angioplasty before.
Okay.
I'm preparing myself to do secondary angioplasty for sure. But in most of the cases, more than 95, you don't need.
Okay, thank you.
You're welcome.
Which brings us to the importance that if we could know before, during thrombectomy, if it's ICAD or it's dissection, it would be very helpful to know what to do.
Yeah, that's what I meant.
Thank you very much, Naci.
You're welcome.
Thank you.
Thank you.